So I have two questions here that are, I believe, kind of tied together. One of them says, CPAP, after 12 years, should you get surgery? And the other one is asking about a device called the HERBST device. And I believe that is a device, so because some of the population it's very difficult for them to tolerate the masks on their face at night for various different reasons. This is a device that you can get through a certified orthodontist or dentist that you wear orally, and it brings the lower jaw forward, because when you lay down, you fall asleep, and all that smooth muscle relaxes. The jaw can come down and create an obstruction, right? It causes that collapse in our airway. The idea is that it pulls everything forward, helping for that collapse not to happen. So if you have strictly obstructive apneas, that may help you. But if the issues are coming more so from your diaphragm or muscle weakness, then it's not really going to help. It may help. You may notice a little bit of an improvement in your saturations, but ultimately, I think if you're having issues because of any sort of muscle weakness or diaphragm insufficiency, then BiPAP is really going to be what's going to help you the best. I'll grab another one. What's a healthy oxygen saturation level for a CMT patient? I think a healthy oxygen level for any patient or person, if you're using a pulse oximeter, normal would be 98 to 100. Plenty of people function between 92 to 100. But I also caution people, if you have those at home for whatever reason, maybe you have another pulmonary history that's coming together with your CMT, be cautious with numbers and go more so off of how you're feeling and a general trend, because all of those devices are different. So if it says 96 and you're measuring your oxygen levels at home and you feel cruddy, but it says 96, if you still feel cruddy and you're short of breath, then you need to make that phone call to your physician and see if you need to go in. And which covers the second question of what would indicate cause for concern. Someone asked about altitude in CMT. Does high altitude have a correlation to increased severity of symptoms and the relationships between oxygen and intake and perhaps cold? So when you're at high altitude, for example, Denver, Colorado, one of my favorite places. So higher altitude means a different pressure of the oxygen that's there. So if you live in California and you have family members in Colorado and you go visit them and you have a history of snoring, and when you go up to Colorado to go visit your family, not only are you snoring, but you're feeling increased fatigue, some shortness of breath, or just difficulty concentrating, then what's happening is those sleep issues or breathing issues that you have here that you're able to just kind of deal with, because of the different pressure of oxygen at a higher altitude, are having a greater effect on you. So that again is another warning sign to go get it checked out. If you live in a place like Denver and you come to Palo Alto, to Stanford for your sleep study, then the pressures that they titrate for you here may not be adequate enough for you in Colorado and Denver. So you would want to share that information so that they know to maybe bump you up a little bit higher for when you go to those areas. Do you want to go?
You want me to take a couple?
Yeah.
So there are a couple of questions on other things. Is there anything for restless leg syndrome? So I assume this comes up in regard to sleep issues. Just to be clear, the sleep specialists differentiate between restless leg syndrome, which is something you experience while you're awake, having trouble sitting still or keeping your legs still, oftentimes right when you're trying to fall asleep, versus the periodic leg movements of sleep, which is when you're actually asleep and your legs just keep moving, which is only going to be really complained about by your bedmate, right? Because you keep kicking them during the night. Nonetheless, the treatment is often similar. We oftentimes try things like gabapentin as we use for painful neuropathies. That can be helpful, or some of the treatments for Parkinson's disease like Mirapex can be helpful as well. So the treatment is usually with medication if that gets to be problematic. Another question was, are hearing tests different for CMT patients than the general population? And not really. So we use the same type of testing, so we'll get audiometry done to see whether or not your hearing is affected. It can be affected in some forms of CMT and not in all. Is there a connection between CMT and muscular dystrophy? And then is it true that with each generation the disease gets worse? There's a connection just because both cause weakness. So the Muscular Dystrophy Association kind of is this big umbrella organization that sees patients with various kinds of peripheral weakness, which includes CMT and muscular dystrophy. But really they're very distinct entities to us. I mean, to neurologists, we differentiate between them. Sometimes there's some overlap, but usually not much. And in general, these forms of CMT do not get worse from generation to generation in a predictable way. Certainly there's enough variation in the severity so that sometimes parents will be minimally affected and children will be more severely affected, but that tends to be more random in CMT compared to other diseases in which there is a predictable progression. So why don't I stop there and let you guys take some more.
Okay. Can I, there's a question on how to test your hands for weakness and CMT. Well, there are some objective standardized ways of testing for strength, but I'm suspecting that if you are losing skill or the capability to do functions, picking up, small objects, or with moving your fingers against force, such as opening your car door, it's possible that you could be losing function. So we look at it in a functional way. If you're unable to perform those tasks that you do every day that are important to you, then it might be an indication that there are some changes going on. A therapist, of course, can do some other more specific measurements, but if it's function related, then if you want to improve your situation, I think you might want to mention that to your doctor to get some help. Someone also asked about energy conservation techniques. What are some examples? So I'm going to list some examples. One is to organize your activities. For example, if you're doing laundry and you have multiple loads, you might want to put a chair down, get some magazines or books, and do your tasks in one spot versus moving around and collecting all that you need in the same space so that you can just do that job and get it done instead of moving back and forth and carrying loads with you. Other things you could do are perhaps keeping duplicates of equipment in different spaces. Have a vacuum cleaner upstairs, a vacuum cleaner downstairs, instead of carting, one between the floors, and that would save you some. Cooking a meal, a big meal on a Sunday, and that way you would have small meals during the week, as well as one thing that people don't realize is that when you're taking a shower, a warm shower that's very relaxing, it has been found to be considered moderate exercise. It relaxes you, your vessels are opened up, and you breathe a little bit harder. If you had a shower chair or something you were sitting down on while you were taking your shower, maybe with a handheld shower nozzle, that might save you some energy. The other thing is to be able to practice relaxation. Deep breathing exercises, yoga, mindful practice can be can help recover from the turmoil of the day. And I think that would be a good practice, as well as practicing good posture and asking for help if you need help, and not, try to be doing it all by yourself, whatever it is.
There's another question here. It reads, my mother had CMT2 and had a paralyzed right hemidiaphragm in her 80s. So the question reads, oh, it's off?
No, I think it's on.
Okay. All right. My mother had CMT too and had a paralyzed right hemidiaphragm in her 80s. Do you see this often, and is there anything to prevent this or delay onset? I can't say that I see it often. But perhaps Dr. Day would be better able to answer that question, that part of the question. What I can tell you from the research that I've read is that issues with the diaphragm are noted in the later stages of life. So as you get to be older, if you are noticing if you're noticing that your sleep is inadequate or that your breathing during the day seems to be inadequate, then perhaps there could be now some new involvement of that phrenic nerve causing some paralysis of the diaphragm. And it's just a matter of getting evaluated and then seeking the treatment for it. It's not like it's something that there's nothing you can do about it, because there's the BiPAP out there. Would you add to that?
All I would say is that hemidiaphragm paralysis is not terribly common. There are certain forms of CMT in which phrenic nerve involvement can happen in more advanced cases. But hemidiaphragm involvement or phrenic nerve paralysis can occur in any population. It occurs just spontaneously sometimes, and we have some ideas where it comes from, but it's not always clear. It almost always comes to medical attention, or at least very frequently does, because people become fairly acutely symptomatic. So we get to see these people and don't always have an explanation for it. So there are some forms of CMT, CMT2A. Certainly I've seen patients with diaphragm involvement, but to have hemidiaphragm would indicate that it might have been one of these other unusual causes that might just be superimposed on the CMT.
Someone asked about recommendations for OT device catalogs or companies. I don't endorse these, but these are ones I use a lot. North Coast Medical is a company that's located in Santa Rosa. They're very good, and they have some interesting things that might be helpful. And another company, Patterson Medical, is a company that is very friendly to consumers, and they have a small catalog that they'll even send you if you're interested. And these have helpful ADL pieces of equipment.
So another question we have here is, how do you know if it's asthma versus CMT or a muscle issue? Asthma is known to be an obstructive respiratory issue, which means that air can come in fairly freely, but the trouble is in getting the air out, hence the wheezing sound. And if you can't get all of that air out, then you can't breathe in as much air in. The easiest way I would tell someone to be able to differentiate between asthma attack and something going on with the muscles or with CMT is if you take your rescue inhaler, such as albuterol, and you feel better, then that's likely your asthma. And if it tends to happen more so seasonally, then you might have like an allergy-induced asthma. But ultimately, I would go to a pulmonologist and have a full pulmonary function study where they actually, so in the clinics we do a simple flow volume loop. You can go to a pulmonary function lab specifically, and they put you inside of a box and have you do a lot more breathing exercises while you're breathing into that filter, and then they can see other values that would help tease that out. Do you have any more?
So I think we have time just for one more question. Are there any more questions?
I guess this is the last one.
Great.
Do hip replacements happen? Do hip replacements happen because of CMT? And yes, people do get hip problems because of CMT for various reasons. Some forms of CMT, notably 1A, can produce hip dysplasia so that there's an abnormality there from the beginning. But just as we were talking about earlier in the day, just the abnormal positioning of the leg can lead to increased wear and tear in the hip and result in the need for hip replacement that way. Certainly falls are increased in CMT patients, and so that increases the risk for hip damage and hip replacement. So I think there's several ways that CMT plays into many orthopedic issues. So.
Thank you so much. Let's give a big round of applause.